Hey you guys, so I hope you guys are doing okay. Just know that I'm praying for you guys about everything. You only have a couple more weeks left, and I just trust me, like I know that third is hard. Like I truly believe you guys on that. I would not want to do it again. I have so much to catch you guys up on in terms of, everything. But we'll get to that. Hopefully, I'm almost done. Is everything hopefully if everything goes okay. But I know that third is so difficult, and with your guys' ATI exam, I know it's probably not the best time right now. And I remember during that time, I felt like I had no time to study for ATI. So I feel like with ATI, I think that I do well on the exams for the most part. There's been a couple of subjects that I didn't really do so well on, but I think it comes down to I didn't put in the time that I should have. So with this, it's a little bit different because in third, it feels like you have no time. And then additionally to taking this med surg one, you also take the peds and you take the OB one as well. I'm not good at the specialties that much. So I feel like med surg is probably my best subject, but I think it really is just about kind of standardized testing in a way. It's really just practice in that type of way, unfortunately. So I'm going to share with you guys what I did in terms of the med surg one. And I feel like I do this every single time, at least from here on out, because there was one specific ATI exam that I was like, yep, I did not do the work for that. And didn't get the best score on it, but at the same time, like, as long as you pass, everything's fine. But so let's see here for the med surg one. So I sent you guys the notes in the WhatsApp group chat. So really what that is what I basically do is I go through practice like A and B, and then I basically like write in all of the questions that I see and kind of just basically the rationales with that. In terms of the set dynamic quizzing, I was trying to think about it. In terms of the set dynamic quizzing questions, I would recommend to do that just because I feel like a lot of people tell you to do the actual dynamic quizzing question set, like where you have to create your own quiz and everything there. Those do help, don't get me wrong, but with MedSurg, it's split up into 20 different things. So this is basically what I did. So let me go to share my screen. So I just have it pulled up on ATI, and then I'll also just go over endocrine things today, just because unfortunately I feel like I have to, because again, neuro was at the very end of the semester, and I feel like I didn't really study it that much. So when looking at it, I was like, ooh, I really need to review this because I feel like I always try to review before I record or I meet with you guys because I feel like that's a little bit unfair. And also, like, I don't know things like straight up ahead. So I think, don't feel bad if it's like, I don't even remember some of the things at the beginning of the semester. Yeah, like I don't remember some of this stuff that, an hour ago I was like, what is this? I forgot what this thing is about. So don't feel bad in that way either if you feel like, oh, I'm supposed to know everything. Yeah, because you're not. That's just how school goes. But anyways, so I'm just waiting for this to load because it's taking forever. Okay, so basically how it works is you have the dynamic quizzing over here. It could just load. And then they make you take the med surg one, wherever it's at, online practice. Yeah, whatever that is. I would actually recommend to take it like multiple times. I only took it once, but to be fair, I feel like it was a time thing on my behalf. I would actually recommend to do it until you get like above an 80%. That's what I would recommend. One, and I used to make notes, so I made like the typing notes right next to it, things I got wrong, and I actually like try to think it through and be like, oh, this one's not right because of this. This one's not right because of this. Because I feel like a lot of us like we're able to just memorize the answers and just be like, okay, this is what the answer is, but really like try to understand the rationales between that. This is everything you guys have heard before, but the one thing that I will say that I feel like has helped me. So you guys have the dynamic quizzing questions here, right? That you do for OB and PEDS. I prefer the standard quizzes ones because it literally is it's a summary of all of the dynamic quizzing questions. And unfortunately, you just don't have that much time. So for med-surg, I actually didn't do the med-surg final one because I did the rest of all of them. And I even did the ones that I was like, I don't know why I need to know this. but I just did it anyways. So it starts all the way up here, I guess. So I literally did all of them. So I did med surge, like cardiovascular. I did dermatology basically too. I feel like there wasn't a lot of questions about that. So honestly, you don't have to do this one. You could probably just look at my notes and just read over it really quick. But I did it. I went over the endocrine for sure, GI for sure, immune and infections for sure, musculoskeletal, yep. I didn't do neurosensory because I felt like there wasn't a lot on it. I didn't do oncology. I did renal and then I did respiratory. So I think I did dermatology only because like sometimes we talk about the skin a lot, and I was like, if the burns are on there, it's also more of an immune thing. But I was like, might as well. It talks a lot about like procedures and stuff like that. And I feel like with like oncology and neuro, one, you haven't even learned neuro yet, but if you wanted to do that, you could. I just did them once, basically all of them, and then I started the final. But that's what I would recommend to do is I basically took them all. I wrote notes on it. Basically, what I try to do is I try to find patterns. So when I was taking practice A and then B, and then at least this is what I do for ATI now. I try to do A and B until I get a 80 or above. And then I try to do all of the rest of these standard ones here. If you don't have time to do the rest of the dynamic quizzing questions. And then I basically do the final. And then on the final, I'll go ahead and just like take it how I regularly take it. I'll redo it until I get above a 90. And so I can try to then write down things that you're seeing in the most common stuff. That's what I would recommend for that. I really, the one thing, not that I can remember, but let me pull up on my iPad really quickly some stuff that I missed on my ATI med surge that you guys should probably go over, just because they probably won't ask the same questions. I don't know if you guys are taking 2019 or 2023 or whatever, but the only reason why I'm saying this is just because I feel like a lot of the time they use the same subjects, but they change like what the topic or the specific subject is on that specific topic. So things I got wrong were there's still quite a bit that I got wrong, but multiple sclerosis, cancer treatment options. So client who is receiving internal radiation therapy, head injury, HIV and AIDS, so home care, infection control. So yeah, I would definitely go over infection control. So anything having to do with like airborne precautions, droplet precautions, contact precautions. And this one specifically was for pertussis, so whooping cough, cardiovascular and hematology disorders, dietary teaching, stroke. The canes always get me. Evaluating clients' mobility with use of quad cane. I can't even remember what I put for that one. Cancer treatment options. So there is quite a bit on cancer actually. So maybe if you want to go over the oncology one, I feel like I didn't, which actually now makes a little bit of sense why I get kind of some of them wrong. But I felt like for the most part, I was like, I'd rather focus on. It was a time thing to like kind of think about like I'd rather go over cardiovascular than go over oncology if you don't have time. But try to do them. That's what I would say. Heart failure, pulmonary edema, furosemide teaching, neurology. There is one here that I see, a lumbar puncture, meningitis manifestations, cardiac catheterization, GI, fecal occult blood testing, head injury, increased ICP, angina and MI. And some of the stuff you learn like literally when you are going over neuro. So angina and myocardial infarction, interventions for angina, hemodialysis and peritoneal dialysis in an AV graft, spinal cord injuries, autonomic dysreflexia, peritonitis, always I feel like on these exams, asthma, diabetes, specifically DKA versus HHS, which literally is kind of unfair because you learn about this in fourth. And then angina and MI, they have quite a bit on angina and MI in a general sense. So planning care, actions to take, evaluating their condition, which I'm assuming this one was a NGN one. So those are some of the stuff that I missed. Oh, and one more: heart failure, pulmonary edema, changes in client status. So probably again an NGN one. So those are some things that I missed that I would focus on too. But really, I would just put these standardized ones, take the final one at the end, try to write down notes in the middle of it too. Things that you notice that you keep seeing. It's kind of like finding patterns, is kind of how I think about it. I feel like one of the more successful ATI ones that I feel like I took was the psych one. One, it wasn't terrible because you're talking about a lot of therapeutic stuff. I think that was a little bit easier to be like, okay, you're not going to say why. But I think it was easy to find patterns in that one because it's like, yeah, you're not gonna, for therapeutic responses, it's like you're not gonna ever say why, so you know automatically this will never be a right answer. And then you usually know that like answers with like always, none, that type of stuff, you kind of have to just be aware like that's probably not the right answer. um and I would just think about it like in terms of testing in a general sense, be safe with yourself. And a lot of people don't mind just kind of clicking a bunch of different things. But I think at the end of the day, you have to maximize the amount of points that you get. So if you're not 100% sure that this is like that is the right answer, then don't click on it, especially if you're talking about like select only apply, stuff like that, because that takes out from you the points you already got. So if let's say there's like 4 out of 5 that you selected and only 2 out of the 5 were actually correct, you're basically, you know what I'm saying? Like you're gonna max out your, or you're going to basically subtract your score that you could have gotten, even if you weren't aware. So I would just say that for the most part, that even goes with like testing on ATI and Canvas in class. Like you shouldn't really be clicking it if you're not sure. And that's like what I feel like is the difference now that I do in testing, is just because like I can't, the way that like sometimes the professors set up point systems, it's like yeah, it's not going to even out your score. And it's like the more that you click, sometimes you can end up like getting the whole question wrong, even though you selected all the all right answers. So just those are general test taking things. I'm trying to remember what else. I feel like it is just finding patterns. And then it's like I just think about psych all the time because I felt like there was a lot of patterns in that one where it's like you're always going to give like this one specific medication first, chloro whatever, for like alcohol withdrawal, and then the next one you'll do is this one, and the next one you'll do is this, and then it's like you know that lithium is going to be on there no matter what. So there are things like that that I'm like you can always see. For med surge, it's different, right? Because you're going over so much material. So that's why I would say for the most part, I would go over this because with these questions right here, unfortunately with the time, you guys, there's like 50,000 questions for you to do on there. And I mean, if you have time to do it, do it. And then look at all the rationales, see what you're going on. But I would definitely take these ones for sure because it's basically a summary of all of them. And then last but not least, I would retake your A and B and literally write down what you're seeing. And then what questions do you keep getting wrong? Because that's what I feel like I did. And I feel like that's what has continued to keep helping me. And just prioritizing that, especially like I know sometimes they say the day before, like don't be practicing questions. For the NCLEX, yeah, don't do that. But for I mean some people are gonna do it anyways. But I would just say like what you for the NCLEX it's different because at that point like you there's no point. Like if you know it, you know it. But for obviously for ATI, it's a little bit different, right? So I would just think about that. And then last thing, with ATI, this is really all I can tell you guys because it's kind of difficult. Um, NGN questions. So they're so long. And then when you go to like fourth and you take some of these exams and stuff like that, it literally is like the longest question sometimes. So um sometimes it can even be like 6 parts. So I would just say for the most part, read the question first and then look at your answers because nobody wants to read the entire thing. So I would just say for the most part, I would really just look at what the patient came in here for. So I'm like, okay, they came in here for this. Cool. So now I'm going to look at like the actual question. And so sometimes it'll be like the vital signs of the like what are complications that we can look out for, and then the interventions and monitors to parameter or whatever. Actually go through all of the different scenarios of what you think is right, but also look for the abnormals. So if it's like which one shows like improvement, like I never read the whole case, I just look at like okay, they're asking for heart rate, okay, this was their heart rate on admission. The second one was this. It's improved. We'll put improved on that one. So that's how you can save time with that, and also some brain power. Because it sucks to like read it and then it's like you go back because you're gonna have to go back to it anyway. So I would just say for the most part, look at the question first, look at your answers, and literally go like one, like look at exhibit one. Okay, this is the heart rate. Okay, they're asking for WBCs. Now I'm going to go to the other one with their labs. Is it out of range? If it's out of range, you're going to select it. If it's in range, it kind of depends on what the question is, but most of the time I feel like a pretty safe way to get these questions right for NGN is like if it's abnormal, you should probably select it. Unless it's something that usually like if it says like immediate follow-up, like you need to tell the provider and it's like they have an infection and their WBCs are high, like, well, yeah, like that's not immediate. Like that's what we're usually going to see with an infection, if that makes sense. So just think about it that way in the way that they're wording it. Because if it's like, oh yeah, they came with the infection, their WBCs are high, I should notify the provider. Well, it's like I can notify the provider after we give them antibiotics and we're doing everything that we can. And if their WBCs on the next day still are becoming higher, then that's something where we want to worry about, because it's like, oh, do they have another infection going on? Do they have now a hospital acquired infection? There are also things like with that, it's like, are you going to prioritize this certain aspect of like the ABCs, or are you going to prioritize, these little things too? So I would just say for the most part, be selective about if you're not really sure about it, probably don't select it just to be safe. And then if it's abnormal, for the most part, click it, unless really just try to think about it if it's like an immediate intervention thing, or if it's an immediate concern that we should notify the provider about. But other than that, that's pretty much my advice for the ATI thing. I feel like it's not that helpful. I'm so sorry. Because I feel like there is unfortunately not really a big way that you can study for it other than doing those questions over and over. But that's what I do. I do the standardized ones because I feel like, again, with your time, you guys don't have a lot of time to do a lot of this stuff. But anyways, so now getting into the endocrine stuff really quickly. And so I have my iPad right here. So I'm not going to go over some of the stuff on there. It's only 5 pages, so I feel like it's not terrible. I hopefully will be able to review stuff with you guys over neuro, but we'll see how that works out because I feel like my schedule is all over the place right now. Okay. And then we're just going to go to endocrine. So I'm going to try to explain some of this stuff to the best of my knowledge. I also have some notes on my computer, so I'll be like looking up and doing all the rest of this stuff too. Not gonna lie, I again feel like I'm a little bit, I don't really remember some of this stuff. And I do feel a little bit all over the place because we're learning like neuro right now, and it's not even the same stuff that you guys are learning in neuro. But I mean, some of it is, but for some of this stuff, like I don't think we have an endocrine one or an endocrine. No, we do, but okay. Anyway, so A&P, basically the reason why you should know the A&P for this is just because if you just understand the why behind it, I feel like then you'll be fine for the diagnostics and everything like that. So really what we're going to be going over is just the thyroid gland and parathyroid gland and how that works. In terms of the endocrine stuff, like for the pancreas, I feel like they don't ask anything about that because really you kind of know everything that you're supposed to know. And I feel like when you get to fourth, they actually kind of up it more with like DKA and stuff like that. So it's a little bit different. But anyway, so with thyroid gland, it basically, what we're talking about is we're talking about metabolism, right? With a thyroid gland, we're talking about what metabolism is. So kind of just the basic metabolic rate. So this basically helps us break down food into like energy sources, helps us with weight management and just our overall health. So that's basically what metabolism is. So that's why I kind of associate hypo and hyperthyroidism with like Cushing's and then Addison's disease, because you really see the same exact kind of symptoms. I feel like for the most part, just because they're dealing with similar issues of having like edema, having like, I feel like specifically with the thyroid stuff, we're seeing more of autonomic changes, and which we'll talk about in a second. So really metabolism, just know that really that this is the breakdown of molecules into releasing energy, basically how our body's able to perform basic functions, like breathing, circulating blood, maintaining the temperature. And then obviously like we usually associate it with like how much we're eating, and then if we're able to lose weight, gain weight, and just overall it helps with growth, repair, yeah, just overall health is how I think about it. So with thyroid gland, it helps produce three hormones. So T3, T4, and then calcitonin. So yeah, thyrocalcitonin and calcitonin, same exact thing. But basically what calcitonin does is that it's activated in response to high serum calcium to decrease calcium. So basically what it's saying is that in the blood, we know that there's high calcium. So as a response, calcitonin will be produced so that it can decrease calcium. So we have this negative feedback between this. So the way that calcium is able to do this is basically from two ways. The way that calcitonin, excuse me, is able to decrease calcium is one, increasing the excretion through the kidneys. So it's able to tell the kidneys, hey, I want you to excrete more calcium because we have too much calcium in the blood right now. So that's the first way. The second way that it does that is basically through inhibiting osteoclastic activity. So remember with osteoclast, it starts with it has a C in it, right? So we're talking about crushers. So they crush down the bone. So remember in the bone, we have calcium in there. If those osteoclasts come to the bone, they crush down the bone, calcium's able to go out, now it's in the bloodstream, right? So if it inhibits osteoclasts, it's saying, hey, don't crush down the bone, we have too much calcium in the blood. So they're not crushing down the bone, they're staying in the bone, and that's basically how it's doing that. So those two ways is mainly how calcitonin is able to decrease the calcium. So in terms of these three hormones, the one thing that you will definitely need is the adequate intake of protein and iodine. So when we're talking about different therapies that we can use for hyperthyroidism, as well as lab tests that we do in terms of iodine, which we'll talk about in a little bit, you absolutely need to have iodine. And usually this is, through our salt intake. And so just know that we require these things in our diet because we need to produce these hormones. In terms of T3 and T4, just you do have to kind of know what they are kind of used for, or what we're looking in for, just because if you don't understand the functions, and I feel like again, like it's a little bit more complicated to understand the manifestations that you see with hyper and hypothyroidism, because once you know like, okay, they're in charge of these things, it's like you're going to see the signs for hyperthyroidism is that everything that they're in charge for is going to be increased, right? So for T3 and T4, they're basically responsible for protein, carb, and fat metabolism. So again, metabolism being, we're breaking down these molecules to release energy. We're using it from our body. Chronotropic and inotropic effects, so heart rate and contractility, and then RBC production, respiratory rate, and their drive. So we'll talk about this in a second, and I'll go back to this whole entire function list for T3 and T4. In terms of the thyroid hormone synthesis, this is a negative feedback system, right? So I think we learned this, through Addison's and Cushing's disease, basically, or in that whole entire endocrine thing in your second semester. So you have T3 and T4 basically are low in your bloodstream. So the hypothalamus will go ahead and secrete TRH, which stimulates the anterior pituitary gland to secrete TSH. That TSH acts on the thyroid gland to secrete T3 and T4. And then more specifically, what we see is that you have that hypothalamus. It's saying, oh, we have low T3 and T4 in the blood. Let's go ahead and release TRH. TRH acts on the pituitary gland to release TSH, and then that TSH activates the thyroid gland to produce those three hormones, so the calcitonin, the T3, and the T4 for that. So now for the parathyroid hormone, for the parathyroid gland, it produces parathyroid hormone. It's also embedded on the actual thyroid gland. So this entire thing is the thyroid gland, and then those four like little circles are located on the back of the thyroid gland. Those are your parathyroid glands right there. So in terms of this parathyroid hormone, it basically does the opposite of calcitonin. So it actually is used to increase calcium whenever there's low calcium in your blood. So it does this by three ways. So it's going to be the first two ways, the same exact way that calcitonin did it, right? So we know that calcitonin, it helps to excrete calcium out of the kidneys. So it's able to say like, hey, go ahead and excrete that all out. And then for the other way, it inhibits osteoclastic activity. So from this way, from the parathyroid hormone, basically it's going to be the opposite, right? So it increases bone reabsorption through osteoclastic activity. It tells osteoclasts, hey, we do want to break down the bone so we can release calcium. So that's the first way, the same exact way as calcitonin, but the opposite. And then the other way is like, yeah, let's tell the kidneys to hold on to the calcium, not excrete them, so we can have more calcium in the blood. So again, just the same exact opposite of calcitonin. And then the very last way that it's able to do it is that it stimulates activation of vitamin D. So when you read about this, it's like, how does this work? Well, basically, just reading the book and just knowing, basically what it does is that it basically tells the intestine to hold on to the calcium with vitamin D. It has some type of relationship there. You don't really have to know that much about it, but just know that those are the three ways. Vitamin D tells the intestine to hold on to calcium. Kidneys hold on to the calcium, and then osteoclasts break down the bone so that you can release calcium, which then increases our calcium in the blood. So this is what I was talking about when I said I will go back to T3 and T4 and explaining this function. So with hypothyroidism, we see a decrease in T3 and T4. And again, we know that they're responsible for protein, carb, and fat metabolism, but really we're kind of more focusing on the conotropic and inotropic effects, as well as the respiratory rate and their drive. So hypo meaning low, right? We're seeing low T3 and T4. What functions or what side effects are we going to see because of that is the decreased heart rate and contractility, right? So the exact opposite, and then decrease in respiratory rate and depth. And then also one thing to know is if we're going to give medications like opioids to a person who has hypothyroidism, you kind of want to know like, okay, if they're already breathing low and they kind of have a low respiratory rate, how much further am I going to drive their respiratory rate down? And those are just little things that you can worry about when we're talking about hypothyroidism. And then right here from this picture, this was actually from my tutor, Lauren. She does great at explaining this stuff. So this basically is just a summary of everything from above. But basically, this is kind of things that you have to remember. And then it talks about osteoclasts and osteoblasts. Remember that they break down the bone for osteoclasts. So they crush down the bone. And then osteoblasts, they help form new bones and they help with growing and healing. And basically, all of those functions are listed there as well. But really, the one thing that I also wanted to note is that with your parathyroid hormone, remember that this will help increase the calcium. But remember, if we're having an increase in calcium, you're also going to have a decrease in your phosphorus just because they have an inverse relationship. So just know that increased calcium going to be the opposite for phosphate. So they're going to keep being at an inverse relationship. So that's what we're going to see throughout these diagnoses and everything. For pancreas, I don't even think she asked as much about it. It's, yep, upper left quadrant, has exocrine and endocrine functions. Endocrine meaning more related to hormones, exocrine meaning more related to substances like sweat and oil. I think we all know it produces insulin, and then glucagon, it has its own negative feedback system with that, right? So really, I don't really think you have to pay attention to that. With diagnostics, same thing. I think the only thing you should read about is the thyroid lab test, and I just mean here. I feel like I kind of summarized it in a way where this is really all you have to know to understand the things behind the conditions. So with CT scan, again, it's going to be the same exact stuff as before. And again, I don't think she'll ask about this stuff. It's just, again, images. We can look at the structures, see what's going on. NPO 4 hours before, it could have with or without contrast. If it does, do you have allergies to iodine or shellfish, metformin? Do you have metals on, pacemakers? And then just drink fluids after so we can get rid of all that contrast through their body. With MRI, same exact thing. It's more specific though. We can ask for consent. Do you have metal in your body, pacemakers, other implanted medical devices with or without contrast? Again, asking for allergies, metformin, and then specifically with an MRI. I added this one because I feel like in the previous study guides, I didn't add it, but I remember like in neuro, she starts talking about like, we're going to have to make sure that they're wearing earbuds and headphones. So I just added it on here. And then no caffeine at least 2 hours before, no smoking 2 hours before, because that can affect the blood flow. So everything that you've seen before really is what we're discussing here. In terms of thyroid lab tests, so RAI, we'll talk about kind of iodine. So remember, again, with T3 and T4, for the production of that, or just for all of the hormones really, and calcitonin, so all three of those, we need to have adequate iodine and then protein, right? So with RAI, basically what is going to happen with this lab test is basically we're going to tell the patient to drink iodine, or we can have them swallow iodine pills. And basically the thyroid gland will either use the iodine or not use the iodine. And so if they use it, basically we're able to see what is their thyroid hormones going to be at, right? Because again, we need iodine and protein so that they can produce and be made. So we'll see if our thyroid gland's able to use that and be able to produce those thyroid hormones. And if they don't, then it's like, oh, hypothyroidism. Well, if they do too much, now you have hyperthyroidism. And so this is a picture that we see right here. And we'll go back to this when we talk about hyperthyroidism and Graves' disease with that. So with TA, this is a thyroid antibody test. It detects autoantibodies for Graves' disease. Remember, autoantibodies are basically, we don't like them. They're antibodies that basically actually attack the immune system. So they help destroy your immune system. So they're not good. We don't like them. And this is usually seen with Graves' disease. And it also can be seen with like Hashimoto's as well with hypothyroidism. For TSH, basically, we're seeing either high or low depending on what condition that they have, and we'll talk about that here. And then with T4 and T3, again, those are our actual thyroid hormones, and that helps us basically understand, are they having hyperthyroidism, hypothyroidism? That's pretty obvious. And then T3RU, you don't really have to know it, but that's just basically saying what's their uptake of iodine, and are they having adequate iodine so that they can produce those thyroid hormones. For endocrine, you can read this. I would just read it once, honestly, because I feel like you don't really have to know this, and I don't think she'll ask. But really, I think this is from past semesters as well. So if you just wanted to know more information about it, read it really quickly. It just talks about, again, some of the stuff with hormones in the endocrine system. So just read it really quickly, but don't worry too much about it. Like, I'm not going to go over it. For age-related changes, same exact thing. Read about it. Everything's going to be decreased with this. You're going to see the same things that you've seen before. And I feel like these are pretty easy to stick out for this. So now talking about the diagnoses. So for hyperthyroidism, so too much thyroid hormones to the tissues. So now they're having an increased metabolic rate. And also now you're seeing more autonomic changes, right? So autonomic meaning like automatically, right? So we know that some of the functions were their respiratory rate and their drive and then their heart rate and contractility. We know that with this, we're probably going to see them all being high as well, right? So with autoimmune, you can see Graves' disease. So I would just associate, like, if you're high, you're going to the grave, right? So don't get high unless, because then you're going to the grave. So remember, Graves' disease is, we're talking about those autoantibodies, right? So these antibodies are made to attack the immune system. So that's why you end up seeing too much production of the T3 and T4. And so other things that we can see here that cause hyperthyroidism is you're having too much TSH from your pituitary gland, remember? So if you're having too much TSH from your pituitary, that will then act on your thyroid to produce the T3 and T4. So really, if let's say you have a pituitary gland issue, let's say you have like a pituitary tumor, you can end up having hyperthyroidism because like, oh, what if they're releasing too much TSH, which acts on the thyroid gland to release too much of the other things. And the same thing can happen with your hypothalamus. Maybe you're having an issue there, releasing too much TSH or TRH to then release TSH to then release T3 and T4. So they all activate. So I feel like when you know the anatomy of it, it's like if you have this issue here, it can cause this next issue to be affected as well, right? And this happens with hypothyroidism as well, but just know that that's basically something that we're looking out for. And then thyroiditis, so if the inflammation of the thyroid gland, which causes it to overwork itself, now we're having overproduction. Neoplastic toxic goiter, so kind of having a goiter here again, leading to the overproduction. And honestly, like inflammation of those cells cause them to be irritated, and that can also cause overproduction. And then obviously with side effects of medications, usually I would say medications have side effects like both hypo and hyper. So like amiodarone is one. Some other ones that I wrote down here. Let's see here. Interferon. So like medications used for like hepatitis or cancer, you can see a lot of issues with hyperthyroidism. Lithium is another one that we can see hypo or hyperthyroidism. And then colony, stimulating factors are other ones that we can usually see as well. So kind of again dealing with like chemotherapy, drugs as well can kind of affect hypo and hyperthyroidism. You don't have to know that, but that's just a fun fact. So risks related to Graves' disease are usually more of is that we're going to see it in women, 20 to 40, and then genetics. So both of these actually are talking about women. Hypothyroidism is going to be a little bit older, a kind of a wider range, and I think it's 30s to 60s. So again, you're seeing more younger women with hyperthyroidism, but really I think it's just both women are at risk for it. Manifestation. So really, yes, you probably will have to be asked about this and pick them out between hyper and hypo. So again, we know that T3 and T4 are responsible for autonomic productions, right? So if we're having too much T3 and T4, we're going to see too much of these autonomic responses, right? So increased heart rate in SV, we're going to see increased carb and protein and lipid metabolism, one of our functions. Because we're having an increase in our metabolism, we're using that food, we're breaking it down, we're breaking it into energy, we're going to have weight loss as a result, because we're breaking all of it down. You're going to have hyperactivity with your bowels, emotional liability. So basically what that means is that you're just changing your emotions a lot. Like you're just kind of a little bit all over the place. Heat intolerance, insomnia, palpitations, sweating, smooth, warm skin, fine hair and hair loss. So again, everything is like elevated is kind of just how I think about it. And then Nick, I just think about it as like, yeah, like it's almost like you're high kind of. Just a lot of things going on. Everything's high. So enlarged thyroid gland. So basically you're going to see a goiter. And again, that is just due to the fact that your thyroid cells are irritated, they're overproducing, they're overworking. So it's going to go ahead and be inflamed and it grows and stretches while you have those overproduction of those cells. The next thing you're going to see too is exophthalmos, which is basically just the bulging eyes. So again, everything's like high, everything's like just exaggerated almost. So I would just think about it like if it's hyperthyroidism, it's going to be high. So for diagnostics, you're going to see increased T3 and T4, obviously, because if those things are high, then you have hyperthyroidism. And so when we're talking about primary versus secondary, I don't think you have to know this, but I think again, it just kind of makes sense when you think about the anatomy or the negative feedback system with what's happening. So with primary hyperthyroidism, we're going to see increased T3 and T4. So that's an actual thyroid gland issue is what it's saying with primary. With secondary, this is more a pituitary issue, right? Because again, the thyroid gland, that's our primary gland. That's what's causing the T3 and T4 to be high. When it says it's a secondary problem, well, this one, it's saying that it could be the TSH. So it's the pituitary that's basically causing, there's a problem with the pituitary. So now it's causing too much TSH, which basically acts on the thyroid gland to produce too much T3 and T4. So if we fix the pituitary gland issue, then we can produce or we can fix the production of the T3 and T4 from the thyroid gland. So basically, it's important to know the differences between that because in practice, I mean, you're going to have access to these resources, but I think it's just important for an exam to know, like, well, you have to understand this process, this negative feedback system, because if it's primary or secondary, I don't think she'll ask, but if you just think about it, if it's primary or secondary, that would change what treatments you're going to do to specific regions, right? If it's like secondary, hyperthyroidism, is that a thyroid gland issue or is that a pituitary gland issue? It's a pituitary gland issue, right? So we're going to treat the pituitary to fix that, so then we can fix the T3 and T4 because the thyroid gland isn't what's causing the T3 and T4 to be high. It's the pituitary that's causing that because it's releasing too much TSH to act on the thyroid gland, which then produces T3 and T4. So it's the same thing. And then also with the hypothalamus, that's more of a tertiary. So that's the third issue that you can have. So too much TRH from the hypothalamus, then pituitary releases too much TSH, which produces too much T3 and T4 because of the thyroid gland being activated. So it's a lot, but I just think about it like the entire negative feedback system is basically just running through my head when I think about this whole thing. So that's kind of how it works with primary and secondary. So basically primary just meaning it's from the thyroid, secondary meaning it's from the pituitary, tertiary meaning probably from the hypothalamus or a different issue. So increased RAI. So again, with the iodine, they're using too much of that iodine. So now they produce too much of those hormones. So that's why, again, you see that overproduction of that. So then it pops up more in terms of the iodine. And that's what you see with Graves' disease, right? So of course, we can always do a thyroid scan and MRI to see what's actually going on. That's kind of just, yep. And then with treatment, anti-thyroid medications, so iodine solutions, basically they make the thyroid less vascular. So that includes Lugo solution and SSKI. That's kind of just memorizing those, unfortunately. I don't have anything for that. But I would just think about it kind of similar to the radioactive iodine, which we'll talk about that in a second. For anti-thyroid drugs, it inhibits TH production, and that includes PTU, methimazole, and then lithium carbonate. So I talked about lithium earlier because it can cause hypothyroidism and hyperthyroidism effects. So that is a medication that we can give for that. In terms of the radioactive iodine, so it is very much similar to like the RAI basically. So what iodine basically does, and I wrote it down here just so I can make sure I'm explaining it right. Let me see where it's at. So basically the way that this radioactive iodine therapy works is basically the thyroid gland naturally uses iodine to produce T3 and T4, right? We need that adequate intake to produce those hormones. So basically with this iodine, the only difference is that it's basically in the name, it's radioactive. So usually, again, we can either give it through a pill or like liquid. And so the thyroid gland will absorb this radioactive iodine, and then this accumulates with the thyroid tissue. It destroys all of the thyroid cells, and then basically that reduces the gland's ability to produce these hormones in the first place, and basically ends up lowering the levels of those thyroid hormones in the blood. So basically it's almost the same thing as like what you're doing, but it's actually radioactive, so it can destroy those cells. For surgery, we can either get a subtotal thyroidectomy or a thyroidectomy for like if they're having any type of cancers going on. Kind of just depends. So really the one things that we're worried about this for complications are hemorrhage. So in the first 24 hours, you just want to make sure that their head's in alignment and you check the bandages for any type of bleeding. Respiratory distress, because again, remember your thyroid functions include your thyroid hormone functions include the autonomic responses, including respiratory rate and drive. So if we're taking out a part or the entire thyroid gland because you're having too much T3 and T4, well, now you're just losing all of that respiratory rate and drive. So you just want to check and make sure that's still intact. And then in terms of other things you're looking at for laryngeal nerve damage, so laryngeal spasms is what you're worried about. And so you should always just make sure you have a trach tray at your bedside. Tetany, which basically is caused by the calcium being decreased. So again, remember the thyroid gland is in charge of producing like calcitonin 2. So you also can see calcium being decreased with this as well. So just make sure that you can see cardiac contractility with calcium being decreased. And then with lifetime thyroid replacement, you're just going to be on lifetime replacement hormones for basically the rest of your life. If you have a total thyroidectomy, which makes sense because now it's all gone. So just make sure you're educating your patients. Yep, you're going to have to continue this for the rest of your life. Because again, like you're not producing anything anymore. So here you go. And then complications just to look out for, which I feel like is what we're going to get into right now. The good thing about this is I feel like the rest of these you kind of already know because it's kind of like, okay, like it's pretty small and obvious kind of like once you know like hyperthyroidism and hypothyroidism, the rest of it just kind of falls into place. So with toxic multinodular goiter, you're basically seeing small discrete nodules in the thyroid. This is more seen in women in their 60s to 70s, so a little bit older than what we see with the hyperthyroidism. But again, this is associated with hyperthyroidism. So basically you see that goiter, and basically that secretes the thyroid hormone. So I would just think about it like you're having that overgrowth of that tissue and that nodule. So we're having those cells be irritating, overproduction of those glands. Same thing with the thyroiditis, right? Inflammation of the thyroid gland, usually caused by a viral infection, but it could basically be acute, but then be chronic. And basically, if you have too many infections or just recurrent infections, it can just destroy that gland tissue, make it permanently inflamed, and that's where you have the overproduction of the T3 and T4 from that. Thyroid storm. So this is the one thing you do have to look at for, and definitely should know this, is the medical emergency for untreated hyperthyroidism. It can be caused, obviously, if the patient already has hyperthyroidism, but let's say now they have like a stressor additionally added. So an infection, trauma, DKA, or manipulation of the gland during surgery. So something happens during surgery. And yeah, so basically mortality rate is high. Manifestations, everything that you saw earlier, basically with hyperthyroidism, but now it's like way more, right? So if we're seeing them being hot, you're going to see them, well, the temperature is too hot, so now they're hyperthermic. Their heart rate, again, functions of T3 and T4. Now it's going to be super tachycardic, hypertension, dyspnea, abdominal pain, agitation, restlessness, tremors, confusion, seizures. So again, everything just more severe. And then priority management, of course, we want to make sure that they're having proper airway, fluid resuscitation, and then we're monitoring them for dysrhythmias because again, heart rate and contractility, and then for seizures, of course. Because just think about it like they're having a lot of energy being broken down, a lot's going on, a lot's happening with the autonomic responses. So you just want to be aware of those seizures, precautions, and everything. So yeah, for hypothyroidism, basically not enough T3 and T4, and this can be caused by multiple different things. Just know that myxedema, in which we'll get into myxedema coma in a second, but myxedema is basically non-pitting edema and connective tissue. So that's what gives people with hypothyroidism the puffy, swollen look. So usually I feel like a lot of people know that people with hypothyroidism have a decreased metabolic rate. So basically they're going to be a little bit thicker and kind of have more of a rough time with losing weight and everything like that. So with risks, again, it's going to be women. It doesn't say genetics on here, always genetics. And then again, it's a little bit older, so 30s to 60s. Patho, so this is what we're talking about when we're talking about primary versus secondary. So primary, this one includes Hashimoto's thyroiditis, in which we'll get to in a second. And then it could be genetics or just something you're born with. It could be basically loss of thyroid after hypothyroidism surgery. So again, with hypothyroidism, we can be taking out their thyroid gland, but now it's like you're not producing enough T3 and T4. So now you have a loss of those productions of those hormones. So now you're hypothyroid. And then with endemic iodine deficiency, again, you need iodine to be able to produce those hormones. So those are things we can look out for. And then amiodarones and other medications, like I talked about earlier, can cause hypothyroidism or hyperthyroidism. So it can go either way. And then for secondary, this is more of pituitary tumor. So again, it's more of a pituitary tumor issue, whereas with primary, we're more talking about a thyroid issue or something's going on. And then tertiary, meaning hypothalamus. Again, going back to that whole negative feedback system that I talked about earlier as well. So with manifestations, so with both of these, you're actually going to be seeing a goiter. So attempt for the thyroid gland to produce more amounts of T3 and T4. So for both, I would just think about it with the goiter, it's inflamed, it's overproducing those T3 and T4. Now for the hypothyroidism, they could also have a goiter, but it's for a different reason, right? The reason that they can have a goiter for hypothyroidism is that it's the thyroid gland has to keep overworking to make T3 and T4. And basically, not kind of as a compensation, but just kind of as an effect, because your thyroid gland's kind of overcompensating itself, it's going to go ahead and just kind of be swollen. And that's where you can see that goiter for that. So I would just think of like they both can have it, but for different reasons. One is because the cells are irritated for one, and then they're being overproduced. And then for this one, it's like your thyroid gland's just overworking itself. So now it's gotten itself inflamed. Manifestations, so fluid retention and edema. So again, it goes down to that mixed edema where they're having that non-pitting edema and connective tissue. So you see that puppy swollen look. So decreased appetite. So everything else is going to be the exact opposite for hyperthyroidism. So everything's high with hyperthyroidism, everything's low with hypothyroidism, right? So decreased appetite, weight gain because they have a slower metabolic rate, constipation, so a slow GI, dry skin, pallor, muscle stiffness, hoarseness, decreased taste and smell. That one's kind of random, but other things that we can see is elevated cholesterol and triglycerides. So again, they're not having they're having a decreased metabolic rate, so that those molecules are having a hard time being broken down to for energy. So now we're going to see elevated cholesterol and triglycerides, which puts them at risk for other issues like atherosclerosis, if they're having any cardiac issues, and then decreased renal flow and glomerular filtration, which leads to low sodium, and that's what also leads to a further like fluid retention and all of those edema and puffy looks that we're getting with hypothyroidism. So for diagnostics, in terms of labs, of course, T3 and T4 will be low. For TSH, so this one, it says low right here, but really it depends on what type of issue that we're looking at for hypothyroidism, right? So, because it could be high. of depending if it's primary or secondary. So to kind of explain this, I would just think about it again, negative feedback system, right? I'm going to explain it one more time. So hopefully you guys have it like in your brains already, because I feel like it's a lot, right? So hypothalamus basically produces TRH. TRH is able to act on basically act on the anterior pituitary gland, and that will produce TSH. TSH will then act on the thyroid gland to produce T3, T4, and then calcitonin, right? So for this specifically, for the labs, of course, with hypo, we're going to say T3 and T4 below. But let's say if it's a pituitary gland issue, your TSH could probably be high. And then as a result, or sorry, your TSH will probably be low. And then as a result, your T3 and T4 will also be low because TSH is not being not being produced enough to act on the thyroid gland to produce T3 and T4, right? But also, if you're having a primary hypothyroidism, meaning that this is more of with your actual thyroid gland, so there's an issue with your thyroid gland, as a negative feedback system, the anterior pituitary gland will be getting, or I guess the hypothalamus gland too, will be getting, hey, there's not enough T3 and T4 in the blood. I think we should probably produce more TRH and TSH so we can produce more T3 and T4. So as a result, you can see an increase in TSH more with a primary problem, whereas with like a secondary problem, it probably is meaning like, oh, something's wrong with the anterior pituitary, so it's low producing TSH, which causes low for T3 and T4, right? Because they act on each other. Whereas again, with primary, it's kind of like, oh, the thyroid just is having an issue. And as a response, your pituitary gland is like, hey, let's probably produce more TSH so we can get this party rolling, right? So it could be both for both things. So just pay attention to what she's asking. Because I think she might have asked this question on the final, at least for Harding. She might have been like, oh, with like primary versus secondary. And I think some people tried to argue with her about it. But if you just think about it, it makes sense, right? Like if it's a primary problem, it's more of a thyroid issue. So you can see that the other glands are probably going to increase their TRH or TSH. Whereas with and usually it's going to be the pituitary gland, like it's not going to really be the hypothalamus, at least not what she talks about. But you could maybe see an increase in TRH, but at least for the labs, for the most part, if she says it's a primary issue, it's like, well, TSH, yeah, will probably be high, but if it's a secondary issue, that means that it's probably just low for the TSH with the pituitary. So with other things that you can see is we'll look at the LDL, cholesterol, triglycerides more with this one, because again, you're having a decrease in your metabolic rates. So you're going to see higher levels, vessels are holding on to them as it's not metabolizing, with what I just said. RBCs, hemoglobin and hematocrit, so look at the H&H for anemia. And again, that goes back to what the T3 and T4 functions are, so RBC production. And then glucose with hypoglycemia, and then sodium, again, going back to the fluid shifting with hyponatremia as well. So treatments we can do are thyroid hormones. So we can give levothyroxine, which is basically just T4. It's a lifelong medication. So basically things to note and things to educate your patients about. Slow dose, then increase. Taken morning, same time every single day. In older patients, we should probably start them at lower dosages just because they have a risk of cardiovascular side effects, as well as decreased albumin and renal excretion just is happening with older patients that we see. So things to note with surgery, subtotal thyroidectomy, we can basically remove the goiter, especially if they're having any type of respiratory difficulty and dysphagia with that as well. For complications, again, it's going to be the same things, but just the opposite. In terms of Hashimoto's thyroiditis, this is the most common type of hypothyroidism. So just like with Graves' disease, that's the medical emergency part. With hyperthyroidism, this one isn't necessarily a medical emergency. It's just more of the same like patho behind it, where it's having the autoimmune, like those autoantibodies, which basically are destroying the thyroid tissue. And basically that tissue is going to be replaced with fibrous tissue, and then the gland enlarges and becomes smaller. And now you're having a decrease in T3 and T4. Again, risks is just going to be being a woman and genetics, and then diagnostics, anti-thyroid antibodies with that, right? So iodine deficiency. So this one again goes with hypo. We know that we need iodine in our diet so that we can produce those hormones. So if you're not having a good iodine diet or you're having deficiency there, you're not going to produce these hormones. So drugs that block TH synthesis. So this can basically be caused through many different ways. One could be your diet. So drugs that block TH synthesis is another way. So drugs that you're possibly taking cause and kind of affect iodine. So lithium is one, and then thyroid drugs, but really like lithium is the main one she talks about. Goitrotrogenic compounds. Basically, it disrupts the production of thyroid hormones because of the foods. And again, it has low iodine, so it could be certain things like those type of foods. And then it also talks about soil deficiency. So again, it can go back to the soil, where they're necessarily located in their environments, in their locations, and in third world countries, they can deal with these type of issues. So myxedema coma, this is basically now the medical emergency for untreated hypothyroidism. And basically this is cause related to hypoxia and CO2 retention with hypoventilation. So remember, T3, T4 function, respiratory rate and drive increases that. So now with this, we're having a decrease in our respiratory rate and drive because it's all low, right? So you're going to see definitely being hypoxic, not being able to breathe enough. And as a result, you're going to have more CO2, right? Because remember, we're talking about acid-base balance kind of, but with hypoventilation, you're not breathing as much, all that CO2 stays in you. And then you're having that retention there. Also with hypothermia as well, and then fluid and electrolyte imbalances. So risk in the elderly, as basically this can be caused if they already have a history of hypothyroidism, but now they also have pneumonia, heart failure, because again, any respiratory problems, you're going to have your drive be down with pneumonia. So now with hypothyroidism too, it could be even worsened. Heart failure, your heart's already like overworking itself. And now it's like you have to deal with like your heart contractility being decreased as well, on top of having heart failure. Not that fun. Same thing with GI bleeds, because again, we're talking about a decrease in like GI motility. CVA, same exact thing. And then again, anything dealing with respirations. So manifestations, severe hyponatremia. Remember with hypothyroidism, you're going to see low sodium, and that's what causes a lot of the fluid retention. Hypoglycemia, you're going to see with lactic acidosis, hypothermia, bradycardia, hypotension, coma, impaired cognition, which basically all goes to, I think about it like if hypoglycemia is going to be one of my effects, you're going to see all of those things with hypoglycemia for sure. So treatment is basically just we're going to replace that the TH that we don't have, right? So we're going to give them levothyroxine, so the T4, right? And then you want to give it to them slowly, because if you give them to do it fast, right, we know that T3, T4 increase heart rate and contractility, so we want to be careful about that. Same thing when you're heating them up, because they're hypothermic. You don't want to heat them up right away, because that can also change a lot of the metabolic rates of what's going on with the oxygenation, right? You'll get more into that about in fourth, but basically you're treating the manifestations. Okay, if they're hypoglycemic, what are we going to give them, right? You're going to give them glucose. If they're hypothermic, let's put like a bear hugger on them. If they're lactic acidotic, what do we can give them? We can give them like bicarb. There are many different things that you can do. Hyponatremic, we can give them sodium. Basically, like you can give them sodium bicarb. Bradycardia, same exact thing. You can give them inotropes. Hypotension, you can give them vasopressors. So there's a lot of different things you can do, but really you're going to replace TH slowly and just treat all those manifestations. Thyroid cancer, so there's different types of cancers right there. You don't have to necessarily know that. But really the one thing she wants you to know for this, again, speaking for Harding's class, manifestations is that palpable, firm, non-tender nodule in your thyroid. So basically, again, talking about like almost like that goiter. And so really same thing as we've always done for the rest of the cancer stuff: biopsy, thyroid scan, treatment, take off your thyroid gland, TSH suppression with levothyroxine, radiation, chemo, doing the same things that we've always done before. So now talking for their last two things, hyperparathyroidism, you're having too much parathyroid hormone. So again, this could be a primary or secondary issue as well. So really with the patho, again, remember with like with the PTH, we're seeing an increase with calcium. Calcitonin, we're seeing a decrease in calcium. So remember that with calcium and phosphate, we also have an inverse relationship. So if you see an increase in calcium for hyperparathyroidism, right, because it's a charge of increasing calcium, we're going to have a lower phosphate as a result. So really, other things we can see that cause this is metabolic acidosis. So increased bicarb excretion causes decreased acid excretion. You can see this in hypokalemia and can be used by bone decalcification and renal calculi. Can be caused through cancer, a lot of different things that we talked about earlier. And then manifestations, asymptomatic, symptomatic, and basically we just want to see if they're hypercalcemic. And then treatments, calcitonin. So you can give them calcitonin to lower calcium. Lasix, so basically they're having too much calcium, so we can give them furosemide so we can go ahead and excrete that all out. And I would just think about it like the parathyroid hormone, you know, that it's able to do these things through three different ways. We can see this through the excretion, through the kidneys, right? Because it's going to hold on to that. You can see it do it through the vitamin D with the intestines holding on to that calcium, and then same thing with the osteoclast. So really, you're just giving calcitonin. With the Lasix, you're getting rid of that. You just want to make sure you keep hydrating them. You can give them phosphate replacement therapy, and then if they need any type of surgery, since this is more related to a tumor issue. And then last but not least, hypoparathyroidism. Now you're having the exact opposite, too little parathyroid hormone. So with the PAPO, you're going to see a decrease in your calcium. So now you're seeing an increase in your phosphate. Really manifestations that we're seeing with this one, this is the more of the one that you should worry about, is the hypocalcemia, right? So I would just look up like hypercalcemia effects versus hypocalcemia effects, but really what you're going to see is be more worried about is this one, kind of, just because we more talked about these type of issues. So trousseau's, so remember this is the T-Rex hands, and then with, I can't say this, but the cheek tremors or things that you're going to see there. And then with numbness, tingling around the mouth, and they can feel a lot of paresthesia in their fingertips, spasms of their hands and feet. So yeah, these are all spasms that you're seeing. And then the tetany that we talked about earlier. So really, these are just manifestations because, again, parathyroid hormone is in charge of increasing calcium. We're not having enough parathyroid hormone, so now there's decrease in your calcium. You can give them calcium gluconate. This will also help them reduce that tetany. For long-term, this is going to involve calcium supplements on a regular basis. And then also we can go ahead and tell them here in your diet, have more calcium. And so again, like we know that that's in a lot of dairy products, as well as vitamin D therapy, if they want to go ahead and take those vitamins, because again, vitamin D basically also is needed to absorb that calcium. And remember, that's another way that the parathyroid can use because of that intestine is able to hold on to calcium a little bit more. But other than that, that's pretty much everything. I love talking about things like this because it's so much easier to understand. As long as you know one, you kind of can know the other. But I would just, again, go through a lot of that negative feedback system and just make sure you understand that, because that really will tell you, like, okay, then these are the signs that we're going to see there. And just remember, hyper, for everything's hyper with hyper, everything's going to be low with the hypo, right? So other than that, that's pretty much it. I wish you guys the best of luck for your ATI exam. Try not to worry too much about it. Trust me, like, you will be fine. I think one thing is that the semester is hard. Like, don't get me wrong, it is. Like, third was difficult, and I remember you're almost there, and it's gonna be Christmas. You're gonna be celebrating, and either way, I'm really proud of you guys. Really happy for you guys, and you're definitely come a long way. I don't really like to talk about being in fourth a lot, just because I feel a lot of, not pressure, but I feel like I'm super superstitious about stuff. And I don't even know why, but I feel like for some reason I'm like, oh, I can't really talk about it until it's really finished. But I also don't want to like worry you guys about fourth or anything like that. But just know, like, if you're able to get through third, like, it is very difficult, and first was very hard as well. But third is different. Like, you don't have enough time. Like, I truly believe, I do not. I'm not jealous of your guys' situation, but you have gotten through it. You only need basically 2 more weeks left, and just keep pushing yourself. I'll let you guys know if I'm able to do the neuro video. Hopefully, I'm able to. But if I'm being honest, I don't remember that much about the neuro stuff. I remember a little bit, but I feel like with that stuff, I really was just like, I'd rather memorize a lot of the other stuff. But just make sure after you take this, I don't know if you guys have another exam. I don't think so. But for the final, I recommend use the final study guide. That was a mixture of Lauren's final study guide, and then I added some stuff in there that I thought that was not necessary, and some stuff that is. It's a lot. If I were you, just actually like go through it, get into a group if you can. I know some people like to study on their own, but I would say just get into a group and just kind of read it out loud together and like highlight it, or at least read it on your own, like go through sections, just because it's a little bit difficult, but try to do this probably after your ATI med surge. Just keep doing those questions and keep working on it. I would do all those things I discussed earlier. And yeah, like try to find those patterns, try to just, be calm through it as much as you can, and just know that it's not the end of the world no matter what you get. Also, standardized testing sucks. And let me just say, by the way, ATI is difficult. And when you actually take the NCLEX, I heard it's a lot different. And I'll let you guys know how that actually goes. But our rates at BC are there for a reason, right? So just trust yourself. You've been through a lot, and I'll tell you guys all about everything by the end of the semester, and I'll probably meet with you guys. Maybe I'll record for neuro again. I don't know if I'll have time to, but worst case scenario, if I don't, I'll go ahead and just meet with you guys for the final, probably either like the Monday before, right? Because you guys have class on Tuesday. And if not, I'll meet with you guys on probably the Saturday. So maybe next Saturday as well. It kind of just depends. Just let me know when your final is. And yeah, I wish you guys the best of luck. Let me know if you need anything. And then again, if you're struggling and you're worried about your grades or anything like that, reach out to me one-on-one. I have the WhatsApp thing. You guys have my email. Just reach out to me privately and we can set up a one-on-one time. Because again, as much as I like doing these recordings and try to help you guys out, I do want to prioritize those students because, I believe everybody should be able to succeed. So other than that, let me know if you need anything. But yeah,